I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi everyone, and welcome to the May 2017 edition of the PRS Journal Club podcast. My name is Jordan Frey, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassador, Shuja Shafqat from Lehigh Valley, and Chad Purnell from Northwestern. Today we have the honor of being joined by Dr. Don Mackay, Vice Chair of Surgery and Chief of Plastic Surgery at Penn State Hershey. Thank you very much, Dr. Mackay, for joining us for this PRS Journal Club podcast.
Thanks for inviting me.
The article we'll be discussing next is entitled, Is Enhanced Recovery the New Standard of Care in Microsurgical Breast Reconstruction? And this is by Dr. Anushka Alfonso, Sabine Oscar, Dr. K.C. Tan, Dr. Joseph Disa, Dr. Babak Marara, Jihan Sehan, and Dr. Joseph Dayan from Memorial Sloan Kettering Cancer Center. As a reminder to everyone listening, all of this month's articles can be read for free on prsjournal.com as always, and this includes also an archive of all past Journal Club articles. So in discussing this article, the authors begin with a background discussing enhanced recovery pathways, or ERPs. And these are pathways that seek to achieve early postoperative recovery by optimizing patients preoperatively and minimizing post-surgical stress. The ultimate goal is to improve outcomes such as early mobilization, optimization of pain control, and earlier hospital discharge. Overall, ERPs, or enhanced recovery pathways, have been shown to decrease morbidity and decrease hospital length of stay. However, the implementation of these pathways, especially in microsurgical breast reconstruction, has been slow, and there's very few limited reports currently available. So with that in mind, the authors therefore sought to examine outcomes at their institution, Memorial Sloan Kettering Cancer Center, a large cancer center based in New York City, after the implementation of their enhanced recovery pathway for microsurgical breast reconstruction with either deep or muscle-sparing tram flap reconstructions. To do this, they looked at perioperative data, which was reviewed for the experimental cohort of patients undergoing immediate or delayed deep or MS tram flap breast reconstruction from April to August of 2015 using their institutional enhanced recovery pathway. This group was compared with a control group of patients undergoing the same procedures from June to December 2013, and this group was typically managed using an opioid-based pain regimen with patient-controlled analgesia, or PCAs. The primary endpoint was length of stay, with secondary endpoints of opioid consumption, pain assessed on a Likert pain scale, and incidence of complications that occurred within 30 days of surgery. The main elements of their enhanced recovery pathway included preoperative patient education, oral clear liquids until 2 hours before surgery, intraoperative opioid supplementation with non-opioid Tylenol, with or without ketorolac or Toradol, transversus abdominis plane or TAP blocks with liposomal bupivacaine, antiemetics intraoperatively, Goaldirected fluid administration, postoperative pain management with Toradol, oral or IV opioids for breakthrough pain with PCAs limited in the majority of patients, as well as finally patient ambulation and regular diet on the first postoperative day, and hospital discharge was expected and discussed with patients preoperatively to be on postoperative day 3. So, in terms of results, 91 patients were included in the study, 42 in the new enhanced recovery pathway group, and 49 in the historical control group. There were no significant differences between the two groups in terms of demographics, the type of procedure being a deep or an MS tram, laterality being unilateral, bilateral, or timing of reconstruction being immediate or delayed. In terms of intraoperative variables, the pathway group used significantly more liposomal bupivacaine, as would be expected, as they were having TAP blocks customarily. They had significantly shorter length of stay, and they received less intravenous fluid compared to the pre-pathway group. Hospital length of stay was 1 day shorter in the pathway group, which was statistically significant, and that was their primary outcome they looked at. The pathway group also used less PCAs, 21% versus 98%, compared to the pre-pathway group, and morphine use overall was also lower in the pathway group. Notably, the pre-pathway group had significantly lower pain scores at time points of 18 to 24 hours and 24 to 48 hours after surgery compared to the pathway group. And this is attributed in their discussion to early patient mobilization, that the patients in the pathway were encouraged to get up the first postoperative day and move around, which the pre-pathway patients didn't always do that, and that caused more pain. Scores for the remainder of the hospital stays were not statistically significantly different. There were no differences in terms of patient complications, readmissions, or reoperations between the two groups. They then performed univariate and multivariate analyses. In univariate analysis, all elements of the enhanced recovery pathway that were introduced, such as tap blocks, postoperative Toradol, goal-directed fluid management, as well as shorter length of surgery, were significantly associated with reduced length of stay and less postoperative opioid consumption. On multivariate analysis, tap blocks were associated with shorter length of stay and less opioid consumption. And lastly, higher intraoperative morphine use was associated with a longer length of stay, while unilateral procedures and older age were associated with less opioid use. Before discussing this amongst ourselves, the authors in their discussion state that while previous studies have demonstrated excellent outcomes with enhanced recovery pathways in microsurgical breast reconstruction, this really represents the first in a heterogeneous collection of patients and surgeons with different practice patterns at a large cancer center, which optimizes the generalizability of this study throughout the country. They attribute their success in weaning opioids and PCAs in their new pathway group to the use of tap blocks and Toradol especially, noting that they didn't observe any increased bleeding, which is always a consideration and concern when giving Toradol intraoperatively and postoperatively. They do lastly note that surgical time was less in the pathway group, which is likely related to their trend of performing these cases with 2 attendings, and they note this is something that could have affected outcomes. So I think in all this is a really important paper and a really interesting paper. I think we've all seen in different hospital systems that we're at that many of our practices are going this way, and we're looking in ways to optimize patient outcomes and optimize cost and having patients being discharged earlier. So this is important, and it shows that microsurgical breast reconstruction can be done in an efficient and effective way with excellent patient outcomes using these pathways. So with that said, I'm really interested, Dr. Mackay, in what you thought about this paper.
I think it's an excellent paper. I think all of us have had clinical pathways in the past, but to really try and analyze where it is that they're effective, this is an important move forward.
In your hospital system, have you noticed areas within plastic surgery where you think there is a need to implement newer enhanced recovery pathways for any other specific patient populations? But where else do you see this going, or do you believe is the future of these pathways?
You know, as we focused on areas of patient safety, and as we've all come under pressure to decrease length of stay, decrease complications, it's provided avenues for projects and implementation of safety pathways that our residents have really got involved in. And there's no question that it makes a difference. Some of the areas that we have looked at are similar to this, with expander and implant breast reconstructions. We found that we had a higher than normal infection rate and a higher than normal readmission rate. So those were 2 areas that we focused on. We changed the way we handle the materials, the implants. We changed the way that we deal with the post-op pain, and that too has borne fruit. So I think when you implement these kind of pathways, just by doing that and examining these things in a little more detail, it yields positive results. We've done it with implants. We've also done it in some of the craniofacial procedures, some of our orthognathic procedures where patients were routinely going to an IMC afterwards, for instance. Now, literally most of them stay overnight and are discharged the following day. And if you're paying attention to each of the little components, it's possible to do that.
I think those are great points, and that actually brings up what I was next going to ask you is what other areas of plastic surgery you saw the need for these enhanced recovery pathways and where you thought there was ground to be made in that regard. And I think, like you mentioned with some craniofacial procedures and orthognathic procedures, that's something we've been seeing as well, especially with our cranial vaults. We've begun to develop these pathways. One other question I wanted to ask related to their protocol in particular, they were giving their patients Toradol on the first postoperative day, or even in some instances, if the case was done earlier in the day, that first evening on postoperative day 0. Is this something you're generally comfortable doing, giving NSAIDs to patients earlier in an effort to reduce pain, knowing that there is some concern for the increased risk of bleeding?
As a rule, yes. So unless there's a specific contraindication, we will give them ketorolac. And even on the first day, later on after the recovery on the first day, on the operative day, not just first day post-op. I think that the fear of bleeding was we became overly concerned with the reports that came out of the ENT literature with bleeding for after tonsillectomies. I don't think that it is quite as high as it once was thought to be.
I'm interested, Shuja, what did you think of this paper?
I really like this paper, and I think it was not just a good paper, but I think it was a really important paper for a couple reasons. One, I think it first forces us to reconsider kind of our traditional dogma of how we think about our standard postoperative regimens and even our preoperative approach to patients, and areas that can be improved even if there isn't necessarily anything wrong with the way we do things now. And so I think that the kind of dogma of being too afraid to give patients NSAIDs and concerns about bleeding is something, and I'd actually be concerned to see if the authors had any change in the way they explained the post-op regimen to patients preoperatively in terms of kind of establishing their expectations. Second, I think it emphasizes the importance of cost savings that Dr. Mackay mentioned. For most of us, anything that saves money and improves patient outcomes but doesn't increase risk is always great. And then third is kind of an area that's been of interest is a concern of physicians prescribing too many narcotics and if that is contributing to the opioid addiction crisis. And I think that is a real consideration, something we need to think about as we go on. But I'd be really interested to see if, at our various institutions, we have different strategies for similar types of protocols. But I think it was really important to study this at a scientific level and prove it in a paper rather than just anecdotally. So, Dr. Mackay, one thing I did want to ask you is, how do you feel that the overprescription of narcotics or just overuse of narcotics by physicians for patients, has it contributed to an epidemic in our country, or has it not? And are there other things at play here?
There's little doubt in my mind that it was a major contributor to this, if not the prime impetus for it. It's not that long ago that we were constantly pressured to abolish pain. The anesthesiologist came out with a campaign that pain was declared the fifth vital sign. And that really set us up for all sorts of trouble. And as recently as a couple of years ago, I was getting negatively scored because I wasn't eradicating pain in my pediatric patients. I wasn't managing the pain as effectively with the non-narcotics, which we're learning more and more about. But there's no doubt in my mind that we, as a profession, contributed to this in a major way, to our shame.
Yeah, I think that's a great point, because I've noticed that as I've gone on in my training, if you hear how patients are cared for on the floor, the over-reliance on their pain level, even on a visual scale, has become so important. And this expectation that sometimes patients might have of the fact that they're going to have no pain after surgery or have very little pain after surgery has changed the way that we've given pain control. And now that we're trying to go back to better methods of pain control that are non-opioid might be difficult, but I think that papers like this are important.
Could I just expand on that a little bit more? I don't want to give the impression that I'm okay with my patients screaming in agony. I think that we can handle this well with a combination of some of the non-steroidal anti-inflammatories and also with local anesthetic. And they outline here the TAP blocks with liposomal bupivacaine. It's effective, it's incredibly expensive. And something that I've used extensively in my patients is pain pumps. And pain pumps with lidocaine, not marcaine. We're looking at that at the moment with our breast recon patients, expander and implant based. And one of the guys who was strongly advocated the Mackay and tap blocks is now gone back to the pain pump. And it's a fairly simple thing that you can apply, and it's cheap. So I will often, and in most cases in fact, at the end of a procedure, when I've done a washout, I'll wash out with a combination of lidocaine and Mackay. Just wash the cavity out and then put in a pain pump with slow delivery of a small amount of lidocaine over the first 2-3 days. And it takes the edge off. The narcotic requirements and prescriptions we write has gone down dramatically as a result of that. So I think that there are ways that we can effectively handle it better than we did with the narcotics. Besides that, when you see, particularly in my patient population with kids, using narcotics in them, it drives me nuts because they all get sick as hell and they start puking and it delays their recovery.
I agree with everything you said. I think pain pumps I'm not sure exactly how extensively they're used, but I think that anecdotally we've seen that they work extremely well. Kind of changing direction, I wanted to ask you something specific about their protocol in terms of their goal-directed fluid management. How do you feel that does or does not affect their post-operative recovery or pain control? Because they didn't necessarily really address that in the paper. They talked about maybe that improving the flap outcome specifically, but they didn't necessarily address how it may have contributed to their post-operative recovery. So I'd be interested to hear what you think about that.
Well, they cite in some of their references that there's an increased thrombosis rate in patients that have been over or underhydrated. I don't know much more about that particular paper, but I think we've all seen the underhydrated patient who then you've got to catch up and resuscitate after surgery. And the same thing is in a lot of the patients who are overhydrated and they look like balloons for a couple of days, particularly after one of these prolonged micro-reconstructions. So I think it's an important aspect to pay attention to. Most of us probably, like us here, kind of relegated that to the anesthesiologist in the belief that they were handling it appropriately. There's much better collaborative teamwork with us now, and we are less likely to encounter either under-resuscitated, underhydrated, or patients that look like balloons afterwards.
Definitely. Chad, what did you think about this paper?
I thought this was an excellent paper. These enhanced recovery pathways are kind of under the microscope now at my institution as well. And after reviewing a lot of the literature behind some of these pathways, I learned two things. One, I think that surgeons in general are way behind the curve as far as how we control pain in postoperative patients. There's a lot of great data out there for a lot of these things that they've incorporated in this pathway. For example, NSAIDs, allowing the patients to have clears up until 2 hours before surgery. And I think a lot of these things, even though there's great evidence behind them, we weren't really incorporating them. And so I'm glad to see from this paper that plastic surgery is starting to incorporate these types of enhanced recovery pathways, but also I'm excited to see that we're contributing to the literature on this. Because I think it's important that as there's more data available and more improved patient satisfaction data with these pathways, I think it's important that we incorporate these into our practice. So I think that these authors provided an excellent kind of template for how we should be incorporating enhanced recovery into our own practices, I think. Dr. Mackay, on that note, actually, I wanted to ask you a question. So these authors have a very comprehensive enhanced recovery pathway between their feeding protocols, their pain protocols, and their fluid protocols. And I wanted to know, what aspects of their particular enhanced recovery pathway are you not using now that you'd like to start using? Or what aspects of their enhanced recovery pathway do you think wouldn't work at your institution?
I think for the most part, they have got an extremely well-developed, detailed pathway. I think it's also important to note, though, that when they're comparing the group that they currently reported on to their historical control, there was one important thing, and you did mention it in your summary of the article, and that is that they have gone more towards 2 microsurgeons operating on the patient. That's going to translate into much shorter operating times. I would argue it's probably going to translate into far fewer complications because you've got 2 relatively fresh microsurgeons doing it. it's difficult then to start pulling out some of those other factors to know how much of an effect it had. So if I can afford it, I'm going to go to 2 microsurgeons as well.
I think that's a great point. We also started doing that at our institution, and it is an important confounder in this paper because these cases just tend to be faster, and it's an easier dissection with 2 microsurgeons. It definitely makes a difference, and I'm sure that affected their outcomes to a certain degree too. So I think it's important to note that.
Those are all really great points, and I think this was an excellent and comprehensive discussion of this really interesting paper, bringing up, like we all kind of said, I think where we see the future of most of medicine and especially plastic surgery, and it is good to see that we're contributing this to the literature, and it'll be interesting to see where this goes. So with that, I think we'll end our discussion of this article, but remember everyone to tune in to the other 2 articles that we'll be discussing on this month's podcasts, as well as all of our previous and future podcasts, which we broadcast every month. And don't forget also to participate in our monthly #PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected article's authors. And lastly, thank you very much, Dr. Mackay, for joining us and discussing this article with us. We really appreciate it.
You're very welcome.